Okay, well, hello and good evening, everybody. Welcome to the DYSIS Smart Colposcopy US webinar. My name is Brent Palmisano. I'm with DYSIS Medical, and I have the enviable task of managing this webinar this evening, so let's hope it goes well. Before we get started, what is DYSIS Smart Colposcopy? DYSIS is the next generation video colposcope with an advanced cervical imaging system. It standardizes every aspect of your colposcopic examination. It allows you to complete normal colposcopy and adds an easy to interpret adjunctive DYSIS color-coded map that objectively quantifies the intensity and the duration of the acetowhitening process to aid in identifying potential areas for biopsy. DYSIS has a medical grade computer, an imaging head or a camera with an integrated acetic acid applicator that applies 1.5 cc's of acetic acid homogenously on the cervix, and it also includes a touchscreen interface for providers to perform all aspects of the colposcopic exam. And I'm pleased to introduce our guest speaker this evening, Dr. Christopher Olsen. He's the president and managing partner of Women's Center for Health in Naperville, Illinois, and clinical associate professor at Loyola University. I'm delighted that we have attendees from across the United States this evening. And with the current lockdown in place, obviously we can't go to you, but with the wonders of technology, we can be here together virtually. Before I hand the webinar over to Dr. Olsen, there's just a few housekeeping instructions that I'd like to share. All microphones are muted to avoid background noise. Please don't hesitate to ask questions, though, via the chat feature on the right-hand side of your screen. We'll ask those questions to Dr. Olsen at the end of the presentation, and we'll do our best to get through as many time permitting as possible. It is with great pleasure that I hand the next 30 minutes or so over to Dr. Olsen, who will share with you his experience of implementing the DYSIS technology into his practice. So, Dr. Olsen, over to you.
Thank you, Brett. I'm getting a little bit of feedback, Brett. Are you getting that?
I hear you loud and clear.
All right, let me keep going and see what happens. I think the echo's gone. Good. So I'm happy to be here tonight to talk about the DYSIS Colposcopy, the digital video colposcope. And Brent, that was a great overview. I can take some of the detail out in the presentation. And also an opportunity to go through a few of the aspects of the improved colpo study, which was a large US-based real-world evaluation of colposcopy in the hands of general gynecologists in the US. First of all, the DYSIS colposcope doesn't take away your standard colposcopy. It allows you to continue to do what you've done every day, evaluate the cervix, use your acetic acid, use your imaging. It provides probably a better screen than you've had before, and also not binocular vision, so you do not put your face up against any machine. You're just looking at a beautiful screen to help bring out any detail that you might need. But in the process of doing your standard colposcopy, the computer takes images every 7 seconds. And the genius behind the technology is figuring out that the most dysplastic cells absorb acetic acid the fastest and hang onto it the longest. And therefore, if you overlay several images every 7 seconds, you can get an idea of which cells are the most worrisome or the most dangerous. And that was the scientific discovery in the late 90s that brought about this technology. This photokinetic response is reflected by the serial images and then quantified based on color, as you can see here in this image. So the most worrisome aspects are white or yellow, and the least worrisome and many times artifact are the light blue. It's also done with a bipolar lens, which takes out a lot of glare. It allows us to superimpose biopsies, as you can see with the number 1 and the number 2 in the area, and then consistently take the map on and put the map back off, or put the map on and off, and see where your biopsies are, so you can compare and contrast your colposcopic impressions. has a green filter, which we're all used to, and then a high contrast filter and magnification, so you can really drill down, which I do throughout the image of the standard colposcopy. So clearly this provides improved detection given your imaging and the addition of the dynamic spectral imaging map. Second of all, it's an enhanced documentation process. So we can review our old video and images from previous scans or previous exams. So if you'd like to compare your colposcopy from last year to this year, if you'd like to show patients your information, and hands down is a much better result than our hand-drawn scrawl on paper, which we're hopefully are of days gone by. And thirdly, it's an improved patient experience. I think the patient can see her cervix and only her cervix. Some other video colposcopes involve just a magnification of everything, the vulva, the vagina, and this is certainly much more palatable to the non-medical person. She can see exactly what you're worried about and what we're following and tracking if you choose to do that. And the reporting and downloading of the information into your EMR is simple. It can be done directly. It can be done with a thumb drive or scanning in the reports as they're generated. So it's an adjunct to your current colposcopy, and that's the disclaimer that we have to sort of emphasize here. The FDA wants us to remember that it's not taking the place of our traditional colposcopy. Although given our current colposcopy being 54 to 56% sensitive, it's nothing to be too proud of, but it's an addition to that exam that allows you to further evaluate and identify the cervix. And then there's the modern version of the newest device there on the left. So this is another reason why it's incredibly important to talk about this tonight. Last month, the ASCCP came out with its new guidelines. Now, you know, they've updated this, what, 2001 and 6 and 12 and 19. So they come out frequently, and it seems like as they're coming out with additional recommendations, a lot of it involves spacing out the interval between how we screen patients. So I'm not going to go through all of this executive summary, but just draw your attention to two things that you're probably already doing. But number two is, if you have someone who has a low-grade lesion, you do a colposcopy on her, and you find that you confirm that it is a low-grade lesion, and a year later with your follow-up pap smear, it shows another low-grade lesion, you don't necessarily need to repeat the colposcopy in that patient. That's new. Second of all, number 5, if you have someone with mild dysplasia or a low-grade lesion and you know she has it and you're following it carefully, you're allowed to continue to observe that lesion as you have done in the past. So we all know sometimes it can take up to 2 or 3 years to immunosuppress the viral changes on the cervix. And so certainly in younger patients and in average age patients, we have been following those things rather than treating them initially like we did in years gone by. But the reason why this is so critical, and the reason why I've asked them to place this slide in here, is because we've got to assume that we're doing the best possible colposcopy that can be done. And our traditional colposcopic exams just aren't our best. When it was invented in the 1920s, there's been very little advance in this technology up until the late 90s and early 2000s. And then now to market here in the US in 2014 and 2015, we finally have a device that can increase our detection rate. So I took part in this. I primarily provided data into the improved colpo experience. It was a large trial that Dr. Cholkeri did a nice job of writing up. It was a 2-arm study. So one arm was those of us doing colposcopy traditionally with the DYSIS colposcope, and then adding the DYSIS map on top of that and evaluating the patient using both those technologies. As a control group, they went back historically to our traditional colposcopies, an equal number of exams, to figure out exactly what we've been detecting and what we've been discovering, and comparing that to the proactive arm, or the DYSIS map arm, excuse me. So it was a real world evaluation, which is hard to say quickly, but it's 45 different clinics all over the country. Some of them were in teaching hospitals, most of them were not, 15 different states and all sorts of different providers. So they had general OBGYNs, gyne-oncs, nurse practitioners, PAs, et cetera, to help contribute the data. Study populations were matched up. It's over 7,500 patients. Average and median ages about the same, premenstrual, postmenstrual the same, insurance, ethnicity, and indication for procedures. You can see there on this, oh my gosh, slide that they line up almost exactly. So the first part of the study, the prospective arm, which is the word I was looking for earlier, was Sarah Denardis did a nice job out of Florida outlining what we were doing. So this was analyzing 881 patients, the initial group of us that were doing the study, and looking at all of our colposcopy, meaning everybody that was being examined from ascus with high-risk HPV all the way up to high-grade lesions. And we compared the yellow bar, us doing our traditional colposcopy, and then after dropping the map over the top of the cervix and then allowing us to make decisions on biopsy based on that as well. And what we discovered is that we identified 44% more women with moderate dysplasia or higher, and 50% more women with severe dysplasia or carcinoma in situ than we did by simply doing our traditional colposcopy. So that was fairly remarkable information. We suspected this all along, but it was pretty eye-opening to find this out. And we did it without a significant increase in biopsies, which was, again, truly amazing. We didn't have a whole large number of false positives associated with that increased detection. This data rolled into the 7,500 patient data, came up with a lot of other information that we're only going to focus on one particular area tonight, and that is the evaluation of the low-grade lesion. So the low-grade lesion, or the ascus lesion with high-risk HPV, the genotype 16 or 18, and the low-grade pap smears is the largest number of people that we evaluate in our offices today. And it was kind of remarkable how many of these patients had moderate dysplasia or higher, or CAN3 or higher, meaning carcinoma in situ. And by simply adding the map, in other words, comparing the control arm, which was the historical colposcopies we've done in the past, to the DYSIS map evaluation of these same type of patients, the detection rate went up 31% for our moderate dysplasia or greater, and 56% for our more severe lesions. Again, emphasizing this was without a significant increase in biopsy. So you've heard before that colposcopy can be improved by increasing random biopsies or 4-quadrant biopsies. It's in fact not true. If you look at the study, and I don't have a slide on this tonight, but as you looked at the number of biopsies and as they increased, it did not increase detection rate in the traditional colposcopic areas, and never did reach the accuracy to that of the DYSIS map. I stand corrected in that. It did increase some of your diagnostic capabilities, but never reached the level of the DYSIS map. So this was just sort of reinforcing the fact that we aren't getting an increased detection rate based on increased biopsies. We're just taking more intelligent biopsies by adding this adjunctive measure. So in summary, the biopsies were better. We outlined again, these were people with an ascus pap or a low-grade pap. Remember, ASCCP guidelines are telling us we can follow these things carefully. We don't need to repeat colpos a year later. We can sit on CIN1s for 1 year, 2 years, 3 years. But that assumes we have the right diagnosis, which you can see, and to a certain extent, we don't have the right diagnosis. So adding this in is critical as we go forward. The detection increases as well as its sensitivity. Again, a true sensitivity can't be calculated without knowing your false negatives and doing a leap after every patient, which of course we don't do. But the true positive rates go up and up and up with the addition of the map. The number of patients undergoing biopsies were similar both in the controls and in the DYSIS group. And again, with the addition of the map in our study, led to only 1 extra biopsy for every 5 patients. They're consistent across all subgroups. And this additional information was critically important. I mean, it changed our management of these patients. Instead of treating them like low-grade lesions, obviously we acted on these. So our practice, a single specialty OBGYN group, we're still an independent private practice. We have 3 nurse practitioners, although none of our nurse practitioners took part in this particular study. We now have them doing colposcopy as we've grown increasingly comfortable with the DYSIS equipment. Wide range of office and minimally invasive procedures. We were early to that market, bringing in these technologies into our office, which sort of got us on the radar when they came time to ask us to participate in this study. As I mentioned before, the sensitivity of traditional colposcopy is less than admirable. There is inter-observer differences, a lot of variability in different colposcopists. My partners manage and biopsy things differently than I do. This variability has led to a lot of concern about not optimizing how we track and how we follow patients. So this particular system allows us to standardize that and again, teach our allied health professionals how to do colposcopy, which certainly added to their work satisfaction. A couple of examples I think that bring home the point. The first one is, can hardly see anything on traditional colposcopy. The map saves us and shows us the most worrisome lesion. And another example that is very, very common is there's a seed of white everywhere across the entire squamous columnar junction. Where the heck do I biopsy to reassure myself that I've gotten the most worrisome spot? First lady, 49-year-old female, gravid at 3, currently on birth control pills for contraception, and she has completely negative history of her whole life. Her first abnormal pap smears in 2012 shows a low-grade lesion. We do a traditional colposcopy without the DYSIS map. We biopsy what we think is the most worrisome, which was mild dysplasia, low grade, perfect. We'll simply follow her. The next year, we repeat her pap smear. It's a atypical squamous cell pap with negative high-risk HPV. Some say that you could then put her into the routine screening pool. We are not comfortable with that. We do not follow her up in 3 to 5 years. We want 2 negatives before we put somebody in the routine screening pool in our practice. And so we repeated her pap smear in 2014, thankfully. Shows another inflammatory pap smear, but now has high-risk HPV, so we're taking her back for colposcopy. This time we have the DYSIS colposcope, again, early on in our experience in 2014. The colposcopy alone, maybe in retrospect, I might have seen something, but initially I didn't see anything. I was satisfied with simply following her, but once I place the map on, I see an extremely small lesion. I direct my biopsy to exactly where that map directs me, and we find a high-grade lesion, and it's confirmed on LEAP. Here's a little out of focus, but the initial reference frame cervix that we could have done a better job of cleaning with the normal saline. And then at the end of acetyl white here, you see some very, very, very kind of frothy-like changes over to the right here. But in general, a fairly normal cervical exam. I would be hard-pressed to do anything with this given traditional colposcopy, especially in light of the fact that the pap smear was only inflammatory. We throw the map on it. Now, please excuse biopsies 1, 2, and 3. We did not take 1, 2, and 3 biopsies. We were teaching residents this day, and we were just showing them how we light up the cervix with biopsies prior to the map and then after the map. The actual biopsy was taken just one in that yellow area labeled number 4. And right in through here, you can just barely see a red and yellow hint of color change. Almost exactly where the X is a red-white lesion, which is why I took it there, but the biopsy almost completely obscures it. Now, you might think that by biopsying this, you've completely excised the lesion and could be able to follow that. The LEAP didn't confirm that, but the biopsy came back severe dysplasia, and we would take her to the OR for treatment. The next example is a 34-year-old female, gravid of 4, period 2. Using condoms for contraception or barrier method. She had a pap history that all we knew is the one that we had done, and that was a low-grade pap smear in 2014. We had the DYSIS colposcope at the time. It revealed acetyl white everywhere across the scapulocolumnar junction, and I was hard-pressed to know where to take my biopsies. The map focused me right into the most worrisome spot, probably to the left of where I would have biopsied, and confirmed moderate to severe dysplasia on a patient with a low-grade pap smear. So here's our initial view. The reference range to the left shows the multiparous os with some ectopy of the scapulocolumnar junction. As we apply the acetic acid, there is acetyl white everywhere. This area here seems to be white. This could be mosaicism up in through here, a little cobblestone appearance. Down in through here looked even more worrisome to me. And there's, of course, several other areas of white, but not exactly sure where I would take my biopsy to make myself feel comfortable that I took a sample from the worst possible area. But as soon as we throw the map on it, there is no doubt where the problem lies. The whitish yellow lesions are screaming at us. We take our biopsies in exactly those locations and confirm the most worrisome aspect of the cervix. I really think these are two great examples of how this particular technology has helped us. It's improved detection for sure. It's enhanced our documentation. That's just a nice little bonus, and improved our patient experience, which is kind of nice as we've go through this healthcare quandrum. But the most important thing is we can catch lesions and these advanced lesions quickly and treat patients more conservatively. Or if we're observing something less worrisome, we feel very, very comfortable that we think we see everything. If our exam is normal with traditional colposcopy and the DYSIS map also agrees with us, we feel more and more confident not treating patients and continuing to follow them conservatively. So we treat lesions that are more worrisome quickly so they don't get more problematic, and we watch less worrisome lesions with the confidence knowing that we've done the right things for our patients.
Dr. Olson, that was terrific. Thank you very much. I am going to change presentation modes and quickly show a video of the DYSIS technology. And then we'll go to directly after this two-minute video. Okay.
DYSIS is a next-generation colposcope with advanced cervical imaging. The instrument is ergonomically designed for either right or left-handed clinicians. Once the speculum is in position, it is attached to the imaging head. The touch screen is used to select and enter the patient's details into the onboard database. A high-resolution image is displayed on the touch screen to enable a colposcopic assessment. Imaging tools include filters and magnification. The acetic acid is automatically applied for homogeneous coverage over the cervix, and the imaging starts automatically. A standard visual colposcopy can now be performed. In the background, DYSIS is timing and measuring the aceto-whitening reaction. Digital biopsy markers can be placed on the cervix at any time during the examination. After you have completed your visual assessment, initial prediction, and biopsy site selection, the DYSIS map may then be displayed. The DYSIS map provides an intuitive summary of the intensity and duration of the aceto-whitening process. Additional biopsy markers can be added using the touch screen. The on-screen markers can guide the biopsy, and the procedure can be video recorded. Your final colposcopic impression must be entered before exiting the exam. Then your colposcopic findings and observations, as well as additional patient notes, can be added as needed to complete the documentation. A patient report can now be generated. In addition, all reports and images can be exported into the patient record. The examination is complete and is captured and stored in the DYSIS database for future review.
Okay. So hopefully you can hear me okay, Dr. Olson. We have a few questions.
Yep.
Okay, great. So the first one actually I'll take. It's can DYSIS be connected to my EMR? And the answer is yes. DYSIS comes with HL7 and DICOM compatibility. So with some configurations, it definitely can be connected to your EMR. The next question, Dr. Olson, is for you. How quickly and easily can you move from a traditional colposcope to DYSIS in terms of a learning curve?
Well, I think very quickly. I think 3 to 5 patients are the maximum that you would need to feel comfortable. Remember, you're doing your own colposcopy for a full 2 minutes. That allows you to feel comfortable with working with the screen and figuring out where buttons are as you're doing your examination. So again, it's helpful if you have somebody there alongside to talk you through that, but patients are fine with that. They appreciate the fact that you're investing in some new and innovative technology. They know you know what you're doing, so it's just a matter of pressing upon them that this technology really has a lot to offer and that you're taking advantage of that technology.
Great. Okay. And here's another one. What about using Lugol's with DYSIS?
Yeah, we get that a lot. So yes, you can use it. It would have to be done afterwards, however. So you're going to use the traditional acetic acid, which it allocates exactly the same amount of acetic acid, and it's a fixed distance from the cervix, which again makes all the difference in the world when you're trying to compare and contrast previous exams. And then once the DYSIS has done its evaluation, the images every 7 seconds for 2 minutes, then you use the Lugol's and do your traditional exam and convince yourself that you agree with your original assessment and the map.
Okay, and the last one I have here is, you touched on it earlier a bit too, but maybe again, how can it help me conservatively manage my patients?
Well, that's the beauty of it. As they continue to ask us to be more and more conservative, I think it's exactly the right recommendation. The problem is you're assuming you have a patient that only has a low-grade lesion, and you're wrong several times. And so that's the beauty of the Smart Track, being able to compare previous exams, being able to go back and look at your images as well, and having those very, very clear, not some pencil drawing where you hopefully can remember, 1 year previously what the image looked like. So I think it's so important now going forward that we have a better way to evaluate the cervix, which is why we invested in it early on. And I'm surprised it isn't just in everybody's armamentarium right now.
That's great. Thank you. Thank you so much for that answer. Thank you for your time, Dr. Olson, this evening with the webinar. Folks who are attending, thank you as well. If you have any follow-up questions, rest assured we'll send you a follow-up email so you have access to reach back out to either Dr. Olson or somebody on our staff at DYSIS. Thank you all. Be safe. Have a great evening. Bye-bye.